Good evening, everyone. Dr. Shivshankar, should we start?
Yeah, we can go ahead. I think Dr. Sonal wanted
Yeah.
to check her slides.
Yeah.
Dr. Sonal.
Sir, I'm good, sir. We can start, please. Yes, sir.
Okay. We'll go ahead.
Okay.
Dr. Sarang.
Good evening.
We'll start.
Welcome
Yes,
all
evening.
to the MCNS webinar. So there is no official announcement from the MCNS, but I would like to thanks our convener, Dr. Shivshankar, and all the moderators. They're putting a lot of efforts to get a good webinar content. And I have a sincere request to all the members to participate actively in the discussion so that it will become more fruitful. So over to you, Dr. Shivshankar.
Yeah, thank you, Dr. Sarang. No, I think we are 8:30 now. We can go ahead with the webinar. Dr. Sandeep.
Sarang, any chance of video correction?
Yeah. Sir is saying something?
Just, I thought just before we start, Shivshankar, shall we just introduce our panelists, if not the moderators?
Yes, sir. Dr. Sandeep.
Yes, sir. Yeah, good evening, all respected chairman, moderator, Dr. Shivshankar and Sarang Gote. So we have a very experienced and elite panelists for today's webinar. First and foremost, the senior most neurosurgeon from Pune, Dr. Dilip Kiawat, sir. Thank you so much, sir, for joining as a panelist for today's webinar. And Dr. Harshad Parikh, sir, is another senior neurosurgeon from Mumbai. Dr. Nitin Londhe, sir, is from Pune. And we have three speakers for today's webinar. And first of all, I would like to appreciate that they have come forward and showed their interest to discuss their complications. It's so encouraging for everyone that someone is coming forward and discussing their complications and maybe for the betterment of the neurosurgical society. Because I had struggled to get the speakers, and when I posted the message on MCNS group, I got 5 now. The kind of members, but I've selected first 3, and all 3 are the fantastic, interesting cases. So I think let's begin with the first case by Dr. Abhijit Verma. He is a MCNS member, basically is from Nagpur, but right now he's practicing in Jaipur. So he's going to talk about the air embolism management, and he's just going to show us what went wrong or right. So Dr. Abhijit, to you.
Thank you so much, sir. Good evening, everyone. And I'm really grateful for MCNS and community for giving me this opportunity on presenting my complication here. So are you able to see my slide?
Yeah, they're seeing. Slide slow and start.
Yes, sir. Yes.
Yes.
So today I'm presenting one of my case which I recently had an encounter with. It's an intravenous air embolism. And what went wrong in that case and what went right? I want to just discuss those findings. So a 72-year-old female patient presented with progressive weakness of left half of the body for 3 months, headache, altered behavior for 2 to 3 months, and occasional vomiting episode for 1 month. There were no comorbidity reported. On clinical examination, the GCS was E4, V4, M6. The left side power in upper limb, lower limb was 3/5. The MMSC score was 20/30 in this patient. The cranial nerves were intact on examination. The Eastern Cooperative Oncology Group performance status was 2 in this case. That is, the patient, before starting of the symptoms, she was ambulatory and she was able to take care of herself and was not in any active work. And the clinical frailty scale score was 4 for looking at her geriatric age. So in the pre-op workup, the MRI showed a right frontoparietal hypertense SOL arising from the FARCs and reaching up to the superior sagittal sinus with perilesional edema and midline shift. And it was a contrast enhancing lesion. As we can see here, the angiogram and venogram, the superior sagittal sinus was patent throughout its extent. And though we can see in this image, the tumor is approaching the superior sagittal sinus, but it's not invading its wall in its entirety. And the tumor was majorly supplied by the anterior circulation. The routine workup came out to be normal, and she was declared a high cardiac risk patient because of her old age. Now, she was positioned in a supine position. Her head was kept in a neutral position with a head ring. Initially, the head end was elevated for 30 degrees to get a better view of the tumor and approach. And a 2 wide bore IV cannula was secured by the anesthesiast team, and it was done in a general anesthesia. The incision was a routine horseshoe-based, broad-based incision crossing the midline. And in craniotomy, I did a large FTP bone flap looking at the edema and the huge tumor size. Intraoperatively, the dura, as expected, was very adherent to the bone. And while doing the craniotomy with the craniotome, I happened to cut the dura towards the superior sagittal sinus side. There was venous bleed from the venous legs, and a small tear was there in superior sagittal sinus, which was managed by Liga clip and surgical patty. And I proceeded with superior sagittal sinus-based duroplasty with ipsilateral interhemispheric approach. And I was able to do a grade 2 excision in this case and around 150 cc of blood loss. Now coming to the event, during the hemostasis process, when I lie down the patties and I covered the operative field with normal saline, as soon as I removed the cotton patties from the previous bleeding side at the superior sagittal side where the rent happened, there was some ooze, which was again managed by Abgel patty and cotton patty. There was no major bleed. But my anesthetist suddenly informed me that her ETCO2 started to drop. Initially, it was 35, now 30 and 25 and again 17. We thought there might be some disconnection of the ETCO2 probe, and her BP was well maintained at that particular time. And as we checked, the probe was like okay. And in this hassle, within a couple of minutes, her BP suddenly crashed to 60 by 40 mm of Hg. Now, as we were suspecting venous embolism in this patient, we halted the procedure. We did a head low position. We flooded the operative field with saline soap and open soaked mop. And vasopressor support was started because it was kept handy, expecting a huge blood loss in such a huge meningioma. And the oxygen was increased to 100%. As the BP and the vitals stabilized, I just put the bone flap. I did a mass closure in this case. Post-operatively, the pupil were reacting in this patient, immediate post-op period. We shifted the patient to ICU. We kept the patient sedated, paralyzed on volume control mode and with 100% oxygen supply. And we nursed the patient in head low and left lateral position. We did an ABG correction in this patient. The ABG showed severe acidosis with decreased and the vasopressor was tapered overnight in this patient, fortunately. Second post-op day, the GCS after sedation was off. We saw it is E2, VT, and 5. Patient was responding, and the patient was extubated on post-op day 2. This was the age ABG, where we can see there was acidosis. So definitely there was a hypoxic injury. This is the immediate post-op day one scan. We can see I didn't get enough of time to do hemostasis. That's why the epidural collection is there. And otherwise, there was no incidence. And this is post-op day 11 scan. Fortunately, the patient survived, and she sent me, obliged me with her photograph with ability to sit and raise her hands and follow commands. So, introspecting after the case with my analysis, what we found we lagged in this case was initially we started with a 30-degree position, but during surgery, I asked my assistants to raise the head and make it more vertical so that I can reach the difficult areas of the tumor, because tumor was like very down and below. And I didn't realize the patient is already like 50 degree, 60 degree in a semi-sitting position. Also, the sinus tier, which we close with Liga clip, I think I would have done a better job if I would have used some sutures to close it more meticulously. The constant saline flow did lag because the focus was more on tumor, and I think it would have helped me. And one more thing is like no central line was secured in this patient. We thought we can manage with two broad, two large cannulas and all. Strong suction in the operative field must have like created a negative pressure leading to suction of the air. What went right for us, fortunately, was I personally had an experience of couple of cases which I saw during my training and my initial years also. So we thought like it is going to a venous air embolism. The head and the lowering, it helped us further, like stopping the air ingress into the sinus. Flooding with saline also helped us. 100% oxygen and timely vasopressor support. So as we all aware of the pathophysiology, in this particular case, what I feel the air must be seeping slowly inside the thing, and the air bubble might have blocked the pulmonary capillary, ultimately leading to the decreased cardiac output and BP in this case. The risk factors, hypovolemia and facial trauma are usually seen in procedures, especially in craniotomy, where the sitting or semi-sitting positions are there, in posterior fossa surgeries. The risk factors are there. Even in the vascular catheter incision or removal, it can lead to such kind of air embolism. Now, coming to intraop air embolism, the incidence is not clear, but the significant cases are reported to be at 3%. And the risk is more in the sitting or semi-sitting position. If there is more than 5 ml per kg of air volume in the veins, it causes a significant air lock, leading to decreased cardiac output. Intraoperatively, the findings which we usually get is like hypotension, tachycardia. There can be a mill murmur could be there. Also, the drop in EtCO2. This EtCO2 probe was like a lifesaver for us, though it worked and we timely detected this thing. It's very easy to get, cheap, and I think it's easily available in every OT. Also, direct observation like air bubbles on venous sporulation. I just got this point from some papers. I'm not sure about it. Also, the most sensitive investigation in such cases would be a transesophageal echocardiogram. It's not easily available, not available with our center as of now. And the most sensitive gas monitor is the end-tidal nitrogen level. In awake patient, the patient can present with chest pain, palpitation, arrhythmias, ECG changes. As already I have mentioned, the non-invasive, the minimum volume of air detected by device, the most sensitive is the precordial Doppler, and the transcranial Doppler can also be used in cases. And in the invasive device, transesophageal echocardiography is the most sensitive device. Now coming to the management part, the immediate actions, what we have to take. First of all, we have to have the sense that this could happen in this patient. We have to be highly suspicious of this thing, and we have to halt the procedure, whatever we are doing, position the head as soon as possible to a neutral position or a lower position and left decupitized position if possible. Flood the field with saline, keep saline mops. Oxygen is to be increased to 100% in such cases, and vasopressor support if the BP are falling. Also, jugular vein compression can increase the CVP and reduce the air entry. in this thing. And in case if the air volume is huge, so we can use the central vena catheter to aspirate the air from the right ventricle also. Thank you.
Yeah. Thank you, Dr. Abhijit, for finishing on time. In fact, before time. So, we would like to have all the questions at the end of the all three talks, right? So, may I request the second speaker, Dr. Sonal, to talk on pseudoaneurysm after putting EVD in case of infective hydrocephalus.
Evening, everyone. Just sharing my screen. Can you see my screen?
Yes, it's seen.
Can I start, sir?
Yeah.
Good evening. I would be speaking on.
Yeah.
Yes, it's just happening. I would be speaking on pseudoaneurysm in a case of post-infective hydrocephalus. I'm Dr. Sonal Jain, and I work as a pediatric neurosurgeon doing exclusively pediatric work in Mumbai. So on history, I have a 9-month-old female. She was born at 36 weeks of life, and there was slow enlargement of head, which was noticed for the last 4 to 5 months. She had mild developmental delay, and there was history of prolonged NICU stay for pneumonia. So the on examination, the head circumference was 52 centimeter, which is abnormal for a child of 9 months old. And the anterior fontanelle was large and lax. There was no neck holding present, and she had this stridor, which was examined by many pediatricians. There was no chest region anymore present, and all of them thought that this was a neurogenic stridor which was present. So the child was somewhere fitting into a picture of a partially treated meningitis, maybe early in life in neonatal time she had an NICU stay, and then she had a slow development of enlargement of head macrocephaly. On imaging and investigations, there were 2 consecutive ultrasound studies which showed progressive enlargement of the supratentorial ventricles, where they commented that the fourth ventricle was not seen or normal, and there was a previous study which documented that all ventricles were normal. We also had an MRI which showed that there was mild dilatation of the supratentorial system again, and there was previous deposition around the basal ganglia, relatively normal fourth ventricle, and aqueductal stenosis. So many such patients we have seen that they begin with an infective picture meningitis, which is partially treated, and then they develop periaqueductal gliosis, stenosis, and so they present like aqueductal stenosis, but it's actually an infected system which is not appropriately treated. So this is the scan, the MRI scan. We can clearly see that the ventricles have blown up. The lateral ventricles and the third ventricle have increased in size, and the fourth ventricle is relatively small compared to these. And there's also some minimal amount of periventricular leukomalacia with minimal ooze which is present. So the impression was hydrocephalus due to post-infective aqueductal gliosis in a child with partially treated meningitis. And the plan was to do an anterior fontanelle tap to see how the CSF is, followed by CSF diversion. If the CSF comes to be having a more neutrophilic predominance and everything is deranged, then we cannot do shunt, and we can look for some other modes of CSF diversion. Considering that there was aqueductal gliosis present, we were also thinking of an endoscopic third ventriculostomy, wherein we use it at least for the time that we treat her with antibiotics and all, and then SOS convert to a shunt if necessary. I understand that the ETV success score in a case of meningitis infection and a child less than 1 year is low, but we are just keeping this option open. So the anterior fontanelle tap was planned on the right side because most of the patients, the right hemisphere is non-eloquent, and because of the neurological stridor which was there, and this child was at a risk of continuing to need the ventilator if once sedated because they lose their airway pretty soon. The child was swaddled and tapped awake with backup for sedation in the ICU only, and we did not use ultrasound guidance because the AF was large. A 20 gauge, which has an outer diameter of less than 1 millimeter and a total length of about 33 millimeter, was used, a vein flow with a tuberculin syringe. At first pass, I got CSF, but there was some resistance. So I inserted the needle loaded with the vein flow both together inside. And then on aspiration, there was blood. Immediately, the needle with the vein flow, everything was removed. And the second pass, I was definitely much more superficial than the first, and there was frank blood which was aspirated, and so the needle was removed. Within 30 seconds or so of this procedure, the child had her first convulsion, and I knew there was a bleed. So we counseled the family because I've been taught in residency that one convulsion in hydrocephalus patient can potentially kill them because the brain goes further into edema and that can compromise a well compensated stage into a very badly decompensated stage. So we counseled the family and we performed an endoscopic third ventriculostomy for this child in next 2 hours. Being a small child, she was already NBM for this procedure because she was being prepared for SOS sedation. So NBM was not an issue, and we took her for an endoscopic third ventriculostomy. The CSF tab then was clear, and I did this on the left side because intraoperatively I used an ultrasound, and I saw that there was a large clot on the right frontal region. So conscious decision was made, and I did this from the left side. Post-operatively, child improved. She was moved to the floor. And then after 2 days, she started having multiple episodes of convulsions, which were not only focal, there were few generalized convulsions also. Majority of them did start from the right side, some of them on the left side. So there was no frank unilateral picture. So we did an ultrasound, we did a CT scan this time. And this is the way the child was convulsing. So the child was conscious. Most of these episodes were focal, but still sometimes they were left, sometimes right, and minimally few they were generalized tonic-clonic convulsions. And she used to come out of them immediately, so they did not require any intubation and all. The child was on minimum oxygen support, then also no EVD also connected. We always leave a reservoir in cases of ETV, especially in dubious ETVs, but she did not require any CSF diversion then. But the CT scan clearly showed that there was a large interhemispheric clot quite deep inside. There was IVH now present, and the ETV was pretty clean, and there was no IVH then, but there's clear-cut occipital horn layering, which is seen now, and there is interhemispheric blood also present. We actually did the CT with contrast because the child was also developing low-grade fever, so we wanted to rule out infection. Later, we understood that this clot may be the reason of the fever. But on contrast, our radiologist picked up there was something in the center, and so we did a CT angio. And the CT angio, we can see clearly here that there is a distal ACA right-sided aneurysm here seen. Okay, this is the aneurysm here seen. It is pretty deep inside, and it is sitting right there. Most likely the cause of SAH now and severe multiple lasting short for few seconds, but still multiple convulsions. So we took this child for interventional neuroradiology. This aneurysm was coiled by Dr. Rashmi Saraf. For this coiling alone, we had to ship the child to Wadia Hospital, to another hospital, because we didn't have pediatric coiling facility available. And we got the child back, and the child is doing very well so far. The endoscopic third ventriculostomy is functional in this child, and she is now 1 year, 9 months old, and no shunt required till date. The summary of the dilemma is that was the needle prick enough to cause a pseudoaneurysm, or was there an underlying predisposition for it? The points for the needle being causing the pseudoaneurysm was that I know my first needle tap was slightly more deeper than usual, but you can see here that pink needle dimensions are, I will just move this part. I hope all of you can see this. 1 second. That the pink needle dimensions are only 33 millimeter. Here it can be seen here, 33 millimeter. And then slowly lower down we use as the child is smaller and smaller, but the maximum can be is 33 millimeter. And the second prick revealed fresh blood, which I knew is some vessel injury, but there was no SH when we did the procedure, and we did the ETV very peacefully actually. And the ultrasound done then revealed a right frontal parenchymal clot. I couldn't gauge the inferior extent of it, so that part is gray if it was still a vessel injury. Points against is there was no IVH seen in the ATV, which is seen in the CSF, which has been collected during the ATV. The child improved immediately for 2 days and then deteriorated again, and still she deteriorated only in the terms of number of convulsions with a new extensive SAH and IVH picture. Clean, sharp needle pricks in one pass usually should not cause pseudoaneurysms. The ones which we see intraoperatively, which Dr. Rashmi Saraf and me were discussing actually, are more caused because of a blunt, irregular, forceful, avulsion suction injury. So a straight needle going in and out, and After that also we have done many taps before it also. So whenever there's a kink in that vein flow, we have to put the needle inside and go and do the tap. So it is not like what in on paper in theory the books explain that the moment we get CSF, we are supposed to remove the needle and let the vein flow pass. Many a times the vein flow passes in, but then kinks at the surface or at the dura, and we have to put the needle again to straighten it, to reposition it. So using the needle for the first time and then mild repositioning has to be done sometimes. But yes, I could have avoided that, and I could have also used an ultrasound to stay strictly on the lateral margin of the ventricle in case we doubt that the needle went in medially and caused the pseudoaneurysm. The second brick was consciously made, was superficial, and still revealed fresh blood. And we did not aspirate at that time. The moment, I mean, I aspirated minimally, and the moment there was blood, I stopped. So no CSF came at that time. It was just blood, and I came out. Thank you. Open for discussion.
Thank you, Dr. Sonar, for nice and crisp presentation. We'll have discussion at the end of all the three talks, so that we can move
Sure,
to
sir.
next. So before I invite third speaker, I request all the participants to post their questions in the chat box so that we can have answers from all the experts, the panelists at the end of the talks, right? So here I invite Dr. Aditya Atal. He is a senior neurosurgeon working in the Max Hospital, Nagpur. So he is going to talk on retrieval of knife. I think it was broken while operating on a lumbar spine.
Good evening, everyone. Is my screen visible to everyone?
Yes, yes.
Shall I start, sir?
Yes, Aditya, it's visible. You can start.
Good evening, everyone. I am Dr. Aditya Atal. First of all, I would like to thanks MCNS and Iratwar sir for providing me such a wonderful opportunity to look back to a complication that has happened couple of years back, and this has been a very insightful journey where I have gone through a lot of literature reviews and I have realized how we could have handled this situation in a better way. So coming to a case, 65-year-old female, she presented with severe low back pain and right lower limb radicular pain. She was unable to walk or stand for more than 5 to 10 minutes. On MRI scan, we can see that there's L5S1 listhesis with pars fracture and movement on dynamic study. So as a routine thing, we have planned for a surgery where L5S1 PLIF was planned. Bilateral L5 and S1 screws were well in place. Laminectomy was done to decompress the canal well. And while performing discectomy, 15 number blade was reported to be fractured by the scrub nurse, and that's when we realized that the fragment is left in the disc space. So desperate attempts were made to search for the retained fragment, and because of failure of all the attempts, I had to ask for a help. I have asked my senior colleague Dr. Hussain Bhati to come and join and see if we can retrieve the fragment. Uh, Multiple fluoroscopic images and then microscopic instruments and microscopic field, everything was used in, and after 2 hours of hard work and radiation exposure, ultimately everything was completely in vain. So that was a time when we decided that it's a good idea to have a peer discussion. We have called some seniors in the town and we have discussed the case with them. And these are the points depending upon which we had to take the further decision whether to go ahead and try for further retrieval or whether to leave that fragment behind in the disk space. So the anticipated complications were migration of the blade, which could lead to neurological or vascular damage, possibility of foreign body infection post-operatively, radiology, like it being a ferromagnetic substance. So post procedure MRI could be a very dreadful situation. Chronic pain or inflammation related to foreign body, and medico legal and ethical aspects related to this particular scenario. So we have informed anesthesiologist that because of this particular complication, the case is getting delayed unwarrantedly. I have informed hospital administration about the particular situation, and an incident report was initiated. Also, I descrubbed when my senior colleague was still trying to retrieve the instrument. I took patient party to a audio video counseling room where I have narrated the entire situation and explained them the scenario and the discussion that we had with our seniors around in the town as well. And we have decided to leave the fragment behind in the disk space because unwarranted trials could further lead to anterior migration of the fragment, which could be potentially threatening because if it reaches into the abdominal cavity or retroperitoneal cavity, things can be really disastrous. And a written consent was taken from patient. Also, everything was documented on a patient education form in the case paper that we had. So ultimately, the blade fragment was left behind, and we went ahead with the closure. So different steps that we have taken in this particular case was we have kept a close monitoring of vitals and neurological deficits. Antibiotics were continued for 1 week. Usually we give 3 post-operative shots of antibiotics. Usually we ambulate on the next day of surgery, but the ambulation was delayed. Also, the discharge was delayed and multiple post-procedural x-rays were done. So this is the immediate post-op X-ray where we can see that in the left side the blade fragment is there in L5S1 disc space. Again, after 1 month, we have done the repeat X-ray when patient was ambulating like for almost 2 to 3 weeks time span. She was ambulating, and we have noticed that there is no change in the position of the disc of the knife fragment. Then comes the ultimate bouncer where the patient landed up into emergency room in midnight with history of gait instability and difficulty in speaking. This was almost like 2 months post surgery, and the emergency medical officer has got an MRI brain done suspecting stroke. Ultimately, it turned out to be hyponatremia and encephalopathy. Patient has recovered well, but when I got a call, I was more worried about the knife fragment. So immediately I got a repeat post MRI. I got an X-ray done, which has shown that there was no migration of the fragment, and everything was looking similar to what it was seen in the previous X-ray. So after that, the patient has never come back for follow-up, and things have just gone missed. In OPD once or twice, they have just come with a regular follow-up thing. And when Sandeep sir has given me this opportunity, I have just connected to the patient, and I could just have a teleconsultation with them where I got to know that patient is doing good. Intermittently, she has back pain and right lower limb pain. She is doing all her routine activities properly. Unfortunately, because of logistic issues, I could not get the patient to our hospital where I would have liked to have a follow-up imaging at 3 years post surgery. Coming to the discussion part, so what was the discussion that has happened during that intraoperative situation where things were really tricky? So the most dreadful thing that we were worried about was the migration of the knife fragment. Uh, so if we dive into literature, there are cases where unwarranted attempts to retrieve the blade has lead to anterior migration, and as we can see that the blade fragment has gone anteriorly into the peritoneal cavity. This is just beside the major vessel. So in this particular case, immediately post procedure, they had to do a laparotomy, and a robotic assisted retrieval of the fragment was done, which has become a dire emergency at that point of time. Coming to a second case, again where such a fragment was left in a disk space, in spite of microscopic and fluoroscopic guided retrieval for almost 1.5 hours, author could not remove the disk fragment, and later on they have put the arthroscope in the disk space with which they could successfully retrieve the fragment. What I currently believe that with the current expertise in spine endoscopy, I think this is the best possible option, if someone is stuck in such situation where you can just put a scope inside. In endofusion and all such techniques, we are regularly putting the scope in the disk space, and we are cleaning the disk space entirely and preparing the end plates. So probably this is the best way where we could have retrieved that particular fragment. Coming to the third case, where the author was able to remove this particular knife fragment with a microscopic posterior approach itself. So I believe that the author was very lucky here, that the disk space was very big, and probably it's all uh, they were at the end they were able to retrieve it. That was the best part. When I went through the literature, there are many more such cases where the fragment was left into the disk space, and at times the fragment could be retrieved in the first surgery itself. There were many cases where the authors have gone back again, redo surgery was done, and the fragment were removed. So, out of all these approaches, there were three major approaches which I have already discussed. Also, I could encounter a very interesting case where, while doing a cervical spine surgery, a metallic fragment was left inside the cervical canal. As you can see, initially the fragment was at level of C4, and with the desperate attempt to retrieve the fragment got moved almost up to C2, C3 disc space. So, after doing a two-level corpectomy and fixation, the author has planned to just leave the things alone, and this is a CT scan that author has done 8 weeks after the surgery, where the fragment was looking stable, and the hypothesis that was mentioned in this particular paper was that probably the fragment got encapsulated by the fibrosis that has happened around the foreign body, which has led to non-migration of fragment henceforth. So, amongst the other complication that we were discussing earlier, MRI for such patients is really dreadful. And like in our case, we had an accidental MRI scan which was done. So I just thought, better to have a literature review regarding that as well. So with the above quoted surgery, with the above quoted in the above quoted paper, they have mentioned that disc space being a very narrow and closed space which is bounded by annulus, ligaments, and post surgical fibrosis. So it becomes a very compact space from where the possibility of migration is reduced. Also, fibrotic encapsulation of the metallic fragment, as we have already seen in the previous study, and also they have mentioned that disc space being avascular compartment, the possibility of magnetic effect of the MRI, magnetic field of MRI, is relatively less compared to the other cavities in the body, like abdominal cavity, where you have a lot of fluid and a lot of free space for migration. Also, as per ACR manual for MRI safety, it is postulated that for a ferromagnetic substance, for a ferromagnetic foreign body substance, at the end of 6 to 8 weeks, there is a formation of tissue ingrowing, which causes fibrotic healing, and the object get stabilized with the surrounding tissue, which reduces the further displacement of the fragments of the foreign bodies. So probably this could be the reason why the the metal fragment left in our case was not displaced after the MRI scan. Coming to the medico-legal aspect of this particular case, informed consent and open disclosure to the family was done. Proper documentation of the intraoperative events were done. Uh, Concerned authorities were informed. Only thing that I believe that got missed is when I have seen the discharge summary. In discharge summary, I have mentioned about the fragment being in the disk space, but in the advice column at the discharge summary, I have not highlighted that MRI should not be done, or it should be done with due precautions. So I believe that that instruction could have definitely helped, and I mean, like, although it went on uneventful, but a better planned MRI could have been done even at the midnight hours. Uh, Coming to conclusion, blade fragment in a disk space is a rare but challenging situation. Retrieval is always preferred when it is feasible and safe. Leaving fragment in situ may be justified in select cases. I have marked it red because I really need opinion from the expert people around here, because in this particular case I want to understand, like, uh, we have not retrieved the fragment, but right now patient is doing fine, and with the evidences that we have studied here right now, how should we go ahead with this particular case? Should we inform patient party to go for a repeat surgery and retrieve uh, the fragment under endoscopic guidance, or what should be the appropriate approach? I would be really happy to get comments on this particular aspect from the esteemed seniors around in this forum right now. Also, importance of imaging, patient communication and prevention strategies need to be discussed and need to be framed properly. Thanks a lot, everyone, and special thanks to Dr. Hussain Bhati, Dr. Lokendra Singh, and Dr. Shivraj Suryavanshi. All of them have helped me in that particular moment where things were very much in dilemma. Thanks a lot.
Thank you, Dr. Aditya, for honest presentation, and you have already answered many anticipated questions. So, before we move on to our respected panelists, I may request Dr. Kishore Chaudhary sir to make his comment based on all the three cases presented here, and then we can move to panelists only, and then we can take questions posted in the chat box. So, to you.
I think all the three presentations were very good, very clear, and a complication that can happen in anyone's hands. So I don't see that as an issue to have a complication. And I think in the first case, I'm not sure about the practice of using a head ring. I thought every patient nowadays, a large tumor, probably you would have three, at least the Mayfield clamp or a Sugita clamp or something like that. Don't know. And also, in my experience, if the meningioma is so large that it's abutting against the superior cerebral sinus, and even if the sinus is patent, my preference is to do a craniotomy on the opposite side, that goes on the opposite side, so that your vertical cut does not injure the sinus. If that does happen, as it does sometimes, then I nowadays I use a pericranial graft because it seals the rent in the sinus very quickly. But I think you did everything right. I couldn't find a fault in what you could have done better when you realized. I use, if I'm opening a sinus, I use most of the times a head up, head down position to such an extent that if the sinus is injured, it bleeds rather than it not bleeding and sucking the air in. So I allow it to little bit bleed and then repair the sinus or patch with gel foam, Surgicel, pericranium, or whatever Durafoam, whatever you're using. So we have a tendency to get worried about bleeding, and we have a tendency to stop the bleeding as a priority, but I think it should be other way around. In such cases, bleeding is actually helpful because it stops the air from getting in. But otherwise, I think whatever you did and whatever you said was everything absolutely fine. In Sonal's case, I think it's very rare. I mean, you did a lateral fontanelle puncture. I don't know how you managed to injure the pericallosal artery, which was central. But of course, it can happen. And sometimes the head is not center, the head is asymmetric. One side is bigger than the other side. It is very easy to injure the vessels. I have never had in such a young age any traumatic aneurysms, but of course it can happen, and thank you very much for highlighting it. And for the last case, I think you did everything right, Dr. Atal. I wouldn't have done anything differently, and I think you have followed up the patient 24 hours, 48 hours, after a few weeks, and again after a few months. From my perspective, I think Dr. Lunde will say more. I think from a medical as well as medical legal perspective, I think I cannot find a fault. You did everything right. So over to the esteemed panelists. All of them happen to be my own teachers.
Thank you so much, sir, for your inputs. May I request Dr. Dilip Kiawat, sir, to...
Yeah, okay. My video is not working, unfortunately, but I'm sure you can hear to me.
Yes, sir.
You all can hear me?
Yes, sir.
Yes, sir.
Yeah. So
Yes,
coming to
yes,
the
we
first
can.
topic of air embolism, I think any tumor, which is a big tumor, vascular tumor coming near to the sinus, we have to be very, very cautious. In air embolism, the best thing is to anticipate it. We should have a high index of suspicion in these cases, and anesthetic should be warned about it. They should use precordial Doppler to constantly monitor it. And of course, it is CO2, as they found, it dropped, and oxygen saturation drops. So I think whatever you did was correct in all these cases. And as Kishore said, that I would give head low position till it bleeds, or put a slight pressure on the jugular vein to allow it to bleed overflow, and then repair it either with pericranium and then stitches and the glue. Rest all is same. I think in the pre-monitoring stage, as I was trained, we used to do a lot of positive forces in sitting position, and we used to constantly irrigate the operation site with the saline. And surgeon will sometimes say, "Oh, look, I can see some air bubbles in the vein," or we could see some gush, we could hear some gush of air, and we should warn the anesthetist that this might happen, and please be careful. Nowadays, of course, we don't do sitting position, and we are having excellent monitoring facilities. So detecting air embolism early in the stage is very, very helpful to prevent further complications. Rest all is same. You have to give oxygenation, you have to do head low, you have to give left decubitus position, and stop your operation at that stage. Second, sonal, I have not seen such case anytime, pricking the vessel and causing a possible pricking of the vessel and causing a pseudoaneurysm, but it looks like a vessel injury which has formed a false aneurysm. Usually, false aneurysm should not make it so fast. It may take few weeks and all that. So it was too early for a false aneurysm to have created. Other than that, of course, you've done a good management, coiling and all.
So, just one point here, sir. That was the discussion we also had with the interventional neuroradiologist side, Dr. Rashmi Saraf, and she said the same thing, that it shouldn't happen so quick.
So fast, yeah.
And also the length of my needle was like 33 millimeter maximum, and I wasn't that deep. So there was a possibility, a very small possibility. I think I will first chew my words and say that maybe I caused it. But a smaller possibility later is a post-infective vasculitis being there, predisposing this child, because the child clearly bled again mostly. The child improved and then deteriorated, but that cannot be ruled out. So, for all learning purposes, practically, maybe yes, I did it, but there's a small possibility that there was something happening, because even the first time, the first prick was a single needle prick, and it did give rise to a large clot again.
The first prick was blood clot, second prick was blood clot. So mostly it is injury to the vessel. And 33 millimeter for a small child is long enough, I think.
Yes, sir, but I wasn't completely inside. Yes,
Yeah,
sir. And
okay.
in fact,
Yeah.
yes, sir. Okay,
Anyway,
thanks.
end result was good, so everything is fine. Now, coming to this horrible experience of breaking knife, everybody must have had this complication in life. I had a couple of times the same thing. The points to teach youngster is that don't panic, don't get scared. If you're doing a microdiscectomy or endoscopic work, extend your incision, do a laminectomy, retract the dura and nerve root nicely, open it up in a better way, open the disc space bigger way, bigger area, and do a two dimensional live fluoroscopy. Then in almost all the cases, you will be able to retrieve it. Otherwise, if blindly you're going to put your disc forceps and remove it, you are bound to push it either into one corner or anteriorly. Coming to this case, I would not have left it inside. I would have probably taken help of laparoscopic surgeon, gone with endoscope, arthroscope from anteriorly, opened the disc space, and retrieved it from there by live fluoroscopy. And sometimes you can use magnet also to pull them out, and it is very, very helpful. Coming to the point of leaving the broken instrument inside, we many times see the disc forceps breaking inside. because of the disc forceps is worn out or overused, and you twist it and it breaks inside, and it creates a similar situation where you have to do all the maneuver, as I said here. And of course, you have to inform the patient, relatives properly, take their written consent, record it um, um, on video. Because if you leave it for a long time, it is going to produce definitely granuloma and complications. The knife pieces which were left inside have migrated towards the vessel. It has also migrated up to the thoracic region. So it has to be removed. You are lucky that nothing has happened in 3 years, but I would be scared. I would just go inside anteriorly and laparoscopically take help and remove it. Okay, I'm done. Thank you.
Thank you, sir. Sir, do you think that, I mean, like after going through all this literature and all, because I have seen that majority of the people, whether it is a second surgery required, they have gone ahead and they have taken out the foreign body. So, what do you think? How should I proceed in this particular case, where at the end of 3 years now, the first action would be in the next encounter when I meet patient, I will be definitely getting radiology done to understand the location of the fragment. But once I locate that fragment, should I counsel patient party to proceed for surgery and try to retrieve the foreign body, or how should I counsel the patient at this particular scenario right now?
In the first place, I would have gone for second surgery, try to retrieve it, either in same incision or from front. Now, since 3 years have passed, patient and you both are lucky that it has remained in the same position. So I think only follow-up of your X-rays will determine what you should do. If it is still moving and migrating, then of course you should not give him a second chance, and you should just go inside, maybe from front, and remove it. But if it is not changing its position by repeated X-rays, I think both of you are lucky and it remains inside.
Thank you, sir.
Sir, it's a case of spondylolisthesis, and Aditya already put the screws. So you must be planning for fusion as well. So for fusion, the complete discectomy could have been done, and you could have put some cage or the bone grafts. So while doing the discectomy, this bone, this scalpel fragment could have been retrieved.
Oh yeah, sorry, I forgot that to include that. This is a case of listhesis where you have put screws and rods, but you have not done any interbody fusion.
Yes,
Yes,
sir.
sir. That's
Actually,
right.
at
Yeah,
the start of the discectomy itself, I
it
have
broke.
realized
Yeah.
that the fragment
Mm.
is missing. So I was cautiously trying to remove the disc, but at the same time, I was little scared about anterior migration of the fragment as well.
Yes,
So
yes.
I tried the best from my side, but then ultimately I thought that it's better to seek a help at that point of time. And then with my senior colleague, when we were trying to the disk space was really narrow, so we thought that we have already put the screws there, so we have used the high speed drill, and we were trying to drill along the end plate so that we can widen the disk space. And if we get a better chance, if we get a better vision, like you rightly mentioned, sir, use of fluoroscopy and try to retrieve it in 2 dimension, we have tried doing all that attempts, but unfortunately we were unable to retrieve the fragment. So at that point of time we thought that if we overdo and if we go for putting a bone graft or doing the fusion part, probably we might, right now, in spite of so much of handling, the fragment was still in the disk space and it has not gone anteriorly. So the decision was made that, just to leave the thing alone there. And we have not gone ahead with the fusion. We have just done pedicle screw fixation, and whatever amount of disc got removed during attempts to retrieve the knife, that amount of disc got retrieved. And as such, no bone fragment or nothing extra was pushed inside the disc space, with the fear that while pushing the bone fragment itself, we might push the knife fragment anteriorly.
Yes, yes. That fear is always there. But maybe by drilling the cortical margins, or sorry, making them raw, you could have put some bone pieces inside. So in future, that area would have fused. But I agree with you that pushing any bone inside would have pushed the fragment of the metal anteriorly. Yeah.
So Dr. Harshad Parekh, sir, your comments, please.
Yes, very interesting problems which all three of you have faced. Uh, First of all, in a meningioma patient, in my practice, we are always putting a central line. Without a central line, we usually our anesthetists don't agree to do. And especially if you are giving an head up about 20 to 30 degree, it is being written in the literature and we have experienced that they are prone to develop air embolism. So suspicion has to be there. And whatever the best you could do is you have done your best. I think this is what it is there. And many a times, lowering the head will increase the bleeding, and we want to, stop the sinus bleeding by elevating the brain head. So this is a catch situation. But if if there was an central line, maybe anesthetist could have aspirated the air. This is what I have experienced many times. I used to do sitting position a lot earlier, not now, and we used to find. I had gone to Yasser and Professor Yasser always used to do in sitting position. And he said very sarcastically in OT, my all patients gets air embolism. I don't know how my anesthetist manages. So this complication can occur anytime in any patient. In this case, I would have asked for a central line and precordial leads so that whenever there is a air bubble is there, it can be aspirated by lowering the head. About second case, I agree with Dr. Kiawat how one can have a needle injury and development of aneurysm. You have put a needle, a bleeding has occurred, again bleeding has occurred. Was it an trauma to aneurysm which was pre-existing? I'm not too sure. I can't say 100%. So it is very difficult to say, but it is something very interesting to understand. Okay, whenever such kind, we used to tap this in JJ Hospital, this fontanelles every day, at least in 2, 3 children, and tap the fontanelle, and we have never encountered such complications. So it's something wonderful to understand and learn that this kind of a complication can arise. Maybe it was there pre-existing and we didn't realize. That may be the possibility. This was I was thinking in that line. But you have managed it very well. Regarding the third case about the knife broken, I was involved into two patients. Once I was on a telephonic discussion with another neurosurgeon who was operating somewhere else, and we discussed. And once I myself washed up with one orthopedic surgeon because he had developed. What we did in that patient is we went retroperitoneally after talking to, of course, the relatives and explaining it, and we have retrieved anteriorly. We had gone anteriorly inside the disc and the disc metal, and we removed the fragment. You were lucky that relatives have agreed and no noise has been made by the relatives. But this is a very difficult situation for a surgeon to handle. And as I agree with Dr. Kiawat, one should try and remove uh, that metal rather than leaving it there. Second time, the same thing. I spoke to another neurosurgeon who was doing, and same thing we did, and we said we go retroperitoneal, and we could manage to do it very easily. So these were the two incidents. It does happen. When I was in England in 1992-93, there was one neurosurgeon who was doing a discectomy, and his disc forceps went right through and through and into aorta. So this is another complication which we have seen happening, and there was a death on the table. So these are the situations which we come across from time to time, and only thing this foreign body should have been removed. I agree with that point. You are lucky that nothing has happened. Patient is okay, fine, good. In case anything further, I think one should try to do retroperitoneal, go there and remove that fragment of the metal. This is what I want to say. Thank you.
One precaution we should always take is inspect the instrument before entering inside, especially the disc forceps. because we use them for years and years. They have gone into multiple cycles of autoclaving. They get weak at their joint. So inspect them before entering inside, and always make it a habit of inspecting it after you come out from the disk space, because suddenly you realize, or you may not realize even that you left something inside. And if the nuts are also not noticed, then it will come to you as a surprise when you do X-ray. So you should inspect it before and after each entry and exit.
It is difficult to drill out that area and go from the same posteriorly and take out that fragment. There is always a fear that fragment may go anteriorly and perforate some of the vessel. So I think we should have another way of doing it. That's what I said, this retroperitoneal approach.
Right, sir. Thank you so
Thank you.
much. So, may I request Dr. Nitin Londe, sir, who has a special background with a medical legal expertise. So, sir, the complication and neurosurgery go hand together, and it's so common. So, how do you look at the complications from your point of view?
Well, first thing, thank you everyone. And most importantly, thank you Abhijit, Sonal and Aditya for your clear-cut presentation and an honest acceptance of what has happened. It can happen to anyone, no doubt about it. As far as the presentations are concerned, they were excellent. And therefore, I will now share my views about them one by one. Coming to first one, which is Abhijit's presentation about air embolism. My personal experience of air embolism has been with not only cranial cases, but also with spinal cases done in prone position. And that is because of large veins which have been opened at, and subsequently maybe since they were not bleeding on the table, their vascular openings were missed or they were not covered with proper amount of fatty and gel foam, and therefore some amount of air embolism has happened. As far as cranial case is concerned, I had experiences of air embolism previously. Of late, I don't have much of them, but I lost one case in one of those cases a few years ago. And what I learned from that case and subsequently what I practice is that whenever, and it was of course a case of meningioma which was adherent to the psoriatic sinus. What I learned from that case is that when I drill holes towards the psoriatic side, first thing is I drill them very much close to each other. Of course, I'm using nowadays the motorized drill. Usually in Maharashtra, we use the man drill, which is very commonly used. And I tend to open on both sides of the sinus, but the burr holes which are made very close to each other. The reason being is that invariably in meningiomas and in elderly people, as was the case in this case, the dura is densely adherent to the inner surface of the bone. So if the burr holes are near each other, then separating the dura under vision is technically easier and possible. And you can make out whether there is a tear or a vein, a large vein which is draining into the sinus, which can accidentally get injured. And quite often what happens is we think it's a sinus tear, but it is not actually a sinus tear. It is a large draining vein into the sinus, which is opened about a centimeter or so away from the sinus, and which can be controlled if it is identified properly. So this has been my experience regarding the meningiomas which was adherent to the psoriatic sinus. Second thing is that I prefer for such cases not to use a craniotome or a drill or a machine to open the or join the two burr holes. What I use is the conventional giggly saw and guide wire. The guide is something which prevents the tear to the dura, and we have all used it in the olden days. I'm sure most of the senior neurosurgeons have used it very frequently. Maybe the youngsters also have had experience and exposure to that, but I use it specifically for such cases. And a pliable guide of the giggly saw is quite useful to prevent dural tear. And especially if the front part of it is angled upwards while inserting it into the burr hole, then it tends to separate the dura from the under surface of the bone quite well before you actually cut the bone with a giggly saw. This has been my observation. The second thing is that as far as air embolism incidence is concerned, it can happen right from the skin. It does not have to be only the sinus which has been open and thereafter the air embolism has happened. Because especially when I have been doing, even in my training days, uh, cases in sitting position or even cervical spine or posterior fossa, and large veins which were there in the intermuscular plane or in the subcutaneous plane, if they were opened, sometimes even we used to get changes of entitled CO2, which was showing changes, and the anesthetic used to make us aware that there is a change, and therefore then we used to take the necessary precaution. Of course, we didn't lose a patient in a sitting position for that reason, but it can happen. I know one instance definitely when I was under training that when that large vein was opened during surgery, even before the entitled CO2 showed changes, or even before the precordial Doppler showed any changes, there was already a brainstem infarct because the direct straight sinus is where the air enters, and then you can get a direct brainstem infarction. So it is not necessary that the air embolism and the neurological deficit will correlate in that case. So this is just an observation which I wanted to share with you. But as far as this particular case of Abhijit is concerned, I think he's done a very good job about how to take care of it. And of course, his subsequent discussion about what is done otherwise in air embolism. But in terms of the ventricular, that is the cardiac ventricular air is concerned, it's a very late presentation. By that time, many things have already happened. So by the time a person is able to identify on a 2D echo or on the cardiac monitor or on the auscultation that there is air in the ventricular system, a lot of damage may have already taken place. So I think subsequent to that, having a central line into the ventricular system and aspirating that is done, no doubt about it, but it may not be as useful at that stage anyways. So this is regarding Abhijit's case. Now, regarding Sonal's case, of course, an excellent presentation, and she's an experienced neurosurgeon in terms of tapping the ventricular system. But I thought when I saw the angiogram picture which you put up, especially in the sagittal plane, that the aneurysm was the bifurcation. So I thought it was a pre-existing aneurysm. And probably when you tap the ventricular system, you decompensated the pressure on that side, and which must have released the pressure onto the aneurysmal wall. And therefore, it must have bled at that time. And that is why you got the CSFs showing blood as well as subarachnoid hemorrhage and all that. So I think primarily it was not a direct injury to the vessel which has led to the aneurysm. The aneurysm was pre-existing. It got decompensated because of your ventricular tap. And that is why the patient has had a bleed. Also is that I want to know from you, why do you use a vent flow? Because you will have a needle inside and you'll have a plastic cover on top of that. Do you keep that vent flow plastic inside for subsequent drainage? Otherwise, one would use a 1.1.5 inch needle, whether it is 20 gauge or 21 gauges in material. That depends upon your choice. But why do you use a vent flow?
The vein flow compared to a direct needle, yes, once we tap and we are in the ventricle without any resistance, we remove the needle and we aspirate from the vein flow, from the plastic thing only. So that's the only reason why I used a vein flow.
Okay,
Because
okay.
it is
Reason why
overall less traumatic.
No, the reason why I asked you this question is because sometimes, very rarely, what happens, and I have seen that in some of my cases, that the needle tends to go ahead, and the plastic part of that vent flow, which is the covering layer, it remains behind and it gets sort of crumpled up, you know, and then that causes injury further. So sometimes this may prove to be a little, I would not say it is always so, but sometimes it might prove to be a little harmful, and that is why I prefer to use only the needle directly. That's my choice, of course.
Okay,
And
okay.
the other thing, I'm sure you have all taken care of the necessary direction of tapping the ventricular system and all that. So it's not something which I think is a part of your technical process which has caused the injury. I think it is basically the decomposition of the ventricular system, the release of pressure on the pre-existing aneurysm, which has led to that particular blood in the CSF. And then, of course, whatever we did subsequent to that has been excellent, and no doubt the patient has done well after that.
Thank you.
Regarding Aditya's case, now this is where I think there are a few points which I feel I should inform you.
Nitin, can I interrupt you once, just a minute?
Please.
Sorry. See, if you say it is decompression of the aneurysm, which is bled, then when she did a tapping on the right side, the CSF was absolutely clear.
Yes.
There was no ventricular bleed.
Yeah.
And any subsequent CT scan also did not show any bleed inside. So that is very less likely that it was a blood in the CSF because of decompression.
No, I'm not saying that also. I'm saying that it has bled in the interhemispheric space. I'm not saying there's a ventricular bleed because of that. Am I?
So according to you, the needle went into the interhemispheric space.
No, not at all. It was in the right place. It was in the ventricle where it should have been, except for the fact that whatever was the tamponade effect of the ventricular system, that having been released, that is why it has bled.
So the blood should be in interhemispheric region, not in the needle.
I think if she puts up her scans again, maybe we can appreciate some points which I have just made.
Yeah. All right, go ahead. Yeah.
Please do it, Sonal, so that.
Yes, sir, I will just put it across. So the first time the bleed was very minimal, but I think what sir means is the pre-tapping. I will just share. Just give me 1 minute, please. Can you see my screen?
Yes, I can. I'm sure others also can. So, I mean, I can't enlarge it on my screen, but if you can enlarge it, I don't know. Enlarge the picture. Yeah. Please go ahead. Enlarge it further. Enlarge it further, please. Now, if we see at this sagittal image, which shows the aneurysm, it's at the bifurcation, isn't it?
Yes.
I mean, that's where we actually expect such data aneurysm.
Actually, the more I look at it, the more it looks like a pre-existing aneurysm to me.
Exactly. My point is that. And now, can we go back to the scan showing the
Yeah,
bleed?
that is why I said, how can it develop so quickly if it was
Yes,
needle
sir.
injury?
Okay.
Even I felt it was pre-existing mostly. That's what.
Well, I'm subject to correction if it is so, no doubt. But this is what I would have thought about it. Yeah. And now coming to Aditya's case about this blade in the intervertebral disc space. A few things which I wanted to point out is, of course, it can happen to anyone. There's nothing odd about it. But one thing is true that consent when a complication has happened on table to take it from relatives outside is not acceptable. First thing is that in this particular case, if that blade is broken in the intervertebral disc space, retrieval of that at that stage is not a life-threatening situation. So therefore, taking consent of a patient's relative when a patient is already on table under anesthesia has no meaning in the court of law. In fact, there's a distinct case law about it, which is the Premanam Katara case. I'm sure Aditya may have read about it, if at all, wherein this sort of a practice was done that the patient was on table and the consent was given by the relative outside the theatre, and the patient's procedure was done subsequently by the surgeon, and the patient got up, and after surgery, of course, the patient, when she got up, he said, I did not consent for it, and therefore the doctor was penalized by the court. And it's a Supreme Court case, so obviously that is the law of the land. Second thing is that whenever we take consent for any procedure, it's an understanding between us and the patient about what we are going to do to him. So anything we do outside what we have already discussed with him is not within the purview of the consent. So unless and until it's a life-threatening situation wherein doing that particular procedure is mandatory on part of the surgeon, one has to not do that procedure, allow the patient to come out. When the patient is fully stable and conscious enough to give a proper consent for the second part of the procedure that the surgeon may be planning, then only it is advisable to that procedure, right? So doing a laparotomy at the same sitting in order to retrieve the blade from the intervertebral disc space, had that intervertebral disc space penetrated and gone into the peritoneum, causing a risk to life? No. In your case, I'm talking, I don't know about the other cases. So in that case, it would not have been advisable to do a on table in the same sitting. If at all it is to be done, it has to be done later by taking a proper consent for that second procedure. So that is one aspect to it. Second aspect to it, legally speaking, there is a terminology known as res ipsa loquitur, which means the thing speaks for itself. Now, any foreign body left
Pardon, sir,
behind.
can you just repeat the terminology?
Res ipsa loquitur. Can I spell it for you? It
It
is
will be great, sir.
res IPSA ipsa loquitur. LOQUITOR. This is the principle of legal understanding, which is very common all over the world. And what it simply means is the thing speaks for itself, which means that any foreign body left inside the patient accidentally, without intention, by the surgeon, is legally liable. Now, in this particular case, I would say the patient has been very benevolent, and maybe your interaction with the patient has been excellent, and therefore it has not migrated into anything further. So that's very good. But as far as any other sort of similar situation is concerned, any time in life, whether the patient has infection, whether the patient has pain, or whether the only incidence of the blade having been left behind itself becomes a point of litigation. Yeah. Now, what it can lead to in the court of law is up to the judge to decide, because there is another few things which we can discuss about it, but at this stage it is not so important. But let me tell you, it can go either way. It can go in favor of the surgeon, or it can go in favor of the patient also. So this is one point. The second point is that in many cases, previously when I was under training, there have been instances when we have left certain things intentionally in the brain, a piece of gauze or patty, because there has been bleeding and it was not getting controlled at that time. So we have intentionally left it behind, and then at a later day, maybe 2 days or 3 days later after the primary surgery, we went in again and retrieved it. So this is a situation wherein we can justify that we have left the foreign body inside the patient's body, but it has been done with an intention. So it is not an accident. It is an intentional left behind foreign body. Whereas in some cases, similar to your case, when it is an accident, then the question arises as to whether it could have been avoided or not, and that is how the discussion will go in the court of law. So that I'm not going into at this stage, because it's a big topic by itself. But let me tell you in very simple words, what it means is that one is that consent should be taken only when the patient is in a position to give consent on the patient on whom you're going to operate, right? Not the relative. Second, unless and until it's a life-threatening situation, do not proceed with other aspect of surgery which may be indicated by you or by other medical science. But if it is not a life-threatening situation, you cannot do that procedure at that time. Yeah? It's like, if a gynecologist is doing something like sativectomy and finds something in the uterus and says, do the hysterectomy at the same time. No, it is not allowed. So something similar I'm talking of in this case. And
Nitin, two questions. Otherwise, I'll forget it.
yes, sir.
The first question is, how can we take consent of a broken knife?
No, you cannot.
We cannot. So then what should you do in this case if the knife is broken and you cannot retrieve it? You tried everything possible on earth.
That's exactly what I was trying to tell Aditya, that do whatever you wanted to do and whatever you had planned to do. Come out. Let the patient come out of anesthesia. Thereafter, once the patient is stable enough, speak to the patient and take a separate consent for retrieval of that blade.
No, now suppose patient goes to the court and tells ki Aditya has made this mistake and I want to sue him. Will he be
No, the patient has a right to sue anyone anytime. That's a different story.
No, not that. In this case, he said I tried everything, I couldn't do it, and I informed you. Now what do I do?
Now
will the court hold him responsible?
No. I will come to that point now. Since you have asked me the question, I'm answering it because I was thinking it would not be a part of this discussion. But anyway, let me tell you, sir. First thing is that this principle of res ipsa loquitur will be applied. And the way in which it is applied is, first, what the court would think or analyzes, was the situation under the control of the surgeon while doing the procedure? That means, was the blade in his hand while blade means the knife, the blade handed, and the blade, was it in the hands of the surgeon while doing it? Or whether it accidentally fell into that particular individual space. So it was not accidentally, it was in the hands of the surgeon. So this is one thing. So the surgeon becomes liable for it. Second is whether the patient contributed to it. That means whether patient was under, I'm not saying in this case, but I have also done spines under local anesthesia once upon a time, not now, once upon a time, long back. So whether the patient was moving and therefore that blade got broken and things like that. If that is so, then it becomes contributory negligence, which in this case it was not, because the patient was under general anesthesia, right? And third thing is that whether whatever has been left behind is creating a problem to the patient. That means whether the patient has pain, whether there is infection, whether there is migration into the peritoneal cavity and things like that. So these are the 3 points which the court will consider while deciding on this particular issue. And then it is up to the individual judge to decide what the judge wants to decide. I'm sure subsequently, since Aditya and the patient have had a dialogue and both are understanding, and the patient is also, as I said, understanding, it will not blow up. But there is a distinct situation at this time when the patient, if the patient decides, can do these, take these legal steps. Am I sort of logical enough to you, sir?
No, sir, you are absolutely logical. And after 3 years, I'm getting all these insights. Probably, it was a really nice learning, and I think it was a message for everyone. And that makes absolute sense, what you mentioned, like during procedure, going out of the OT, and then discussing getting the audio video consent and a written consent. I think that's how I was advised from my seniors at that point of time. There were two senior neurosurgeons along with me. One was over a phone call and one was in the OT. So I have just followed what they have informed and what they have instructed me. But I believe that what you have mentioned makes a lot of sense.
Yeah, I mean, what I told you is how the judiciary looks at consent as an issue. Consent is something which has to be obtained before any procedure. That is a fact. That is exactly why we do consent before any. Sorry. Anyway, consent is something which we take before surgery and we explain to the patient and the relatives. But most important is that the patient has to sign, unless it's a child below 12 years of age.
Yeah, but in case of accidental incidents, what
Yes,
will
sir.
you do? You have to inform the relatives at the same time, go outside and talk to
What
them.
you said is
Otherwise,
right,
they'll say,
sir.
why you didn't inform us?
The first thing, sir, first thing is that the law and the judiciary does not recognize anything as medical accident. There is no such concept. Though,
One question, sir. Does it
Yes.
remain a complication or it's a negligence? How does the judiciary look at this incidence? Is it a negligence or it's a complication?
if it is reported in the textbook as more than 1% of incidents, then it is under complication.
It's not
If it
reported,
is,
sir.
if it is not so in the textbook, then it is under negligence.
Yeah, but it is reported. It
Case
is
reports
reported in the
is not
literature. Report in the
case,
literature.
There
case
are
report is
many,
not literature.
there are many
Reported in the
case
literature,
reports.
yes.
See, can I be a bit more clear in what I said?
Sure.
The judiciary will interpret any sort of post-operative untoward problem as a complication primarily. That it is a complication, whether it is reported in the literature or not. What they will decide is whether the surgeon could have avoided it. If it is avoidable and he had taken steps to avoid it, and despite which it has happened, then it is an accident. But if he had not taken the necessary steps to avoid it, knowing that this is a problem which can happen, then it is a negligence.
So if you're a judge and a neurosurgeon both, what would you call this incident?
Good question. Good question.
You want to put words
That's
in
a
my mouth?
direct question.
Yes, correct.
Well,
And
we
you
will
are in a
have to-
position to answer.
No, I'll tell you what. It's not that I will make any suggestion regarding the outcome of this. First and foremost, what is essential is whether anything which is decided upon is something which the patient has to first complain about. If the patient is not complaining, there's no case. If there's no case, there's nothing to be done. Simple as that.
No,